So the next topic for debate is up, headache. Should everyone get a CTA? And I think this is one of the most invaluable topics in current medicines, the CTs and the CTAs. So for this, I would like the two speakers, Dr.Latha Ganti and Dr.Luis Herrera Robles. Please join me on the stage. So Dr. Latha, Professor of Emergency Medicine and Neurology at the University of Central Florida, extensive experience and an international accomplished person who has multiple awards to her name and credit. I would like to invite Dr. Latha to start the talk by saying why should everybody get a CTA when he's suffering from a headache?
We did it as no yes.
No yes? Okay. So there you see. The democracy works, right? They decided themselves that they're going to go no yes rather than yes no. So let me then introduce Dr. Luis Herrera Robles. Dr. Luis was, prior to joining to Cleveland Clinic, was the assistant professor and director at the University of Toronto, Ontario, Canada. Again, has an extensive academic experience in running residency programs, trauma resuscitations, and teaching fellows. So without further delay, I would like Dr. Robles to start the talk on no, not everybody should get a CTA when he's suffering from a headache.
Thank you. So let's just talk about a supraarachnoid hemorrhage, and most of you guys either emergency or people that have dealt with this before. This is the next one? Yeah. Okay. Okay. Yeah, it's gone. Yeah. Okay. So I have no disclaimer. So essentially, let's just look at some of the background about supraarachnoid hemorrhage. It's around 2% of all the headache visits that we have in the emergency. Around 1% of these headaches that we get are related to supraarachnoid hemorrhage. So look at the numbers, and then you have to be careful in some of the papers that you read about, are you in the 700 category or doing LPs and things of that respect. If you are in an emergency that sees around 50,000 visits a year, okay, 2% of that will be 1,000 headaches in totally. 1% out of that will be a true supraarachnoid hemorrhage. So that's 10 headaches out of that 1,000 number. So the first things that we have to take into account here is that supraarachnoid hemorrhage is a rare condition. Not every single headache that comes to the emergency is a supraarachnoid hemorrhage. The other message that I definitely want to relate in this is it is a killer. So pay attention to this, do a great history, do a physical examination, and even if you miss this, they also have a significant morbidity with a residual neurological deficit in up to 40% of the patient and significant in 20% of the patient. If we're not careful, the literature code that we miss around 5% of this patient. Okay. So let's just illustrate some of these issues with a case. So 45-year-old male, sudden onset of severe headaches, 9/10, with described as the worst headaches that he ever experienced. This happened post-sexual intercourse. That was a patient that I saw in Canada. He was pre-syncopal and described this as a different headaches, that he never had this before. And one of the questions is I never go and say, well, is this your worst headache? That's a misleading. It's like, well, why are you here? What is it that is different on this headache? And then people usually tell you what the issues are. Healthy, he got some improvement with Tylenol. Just for the audience in here, so how many of you guys, for a headache to rule out supraarachnoid hemorrhage, have done an LP in the last week? Just raise hands. So there is one in there. In the last month, for supraarachnoid hemorrhage, I'm not talking about meningitis or anything, there's 2, okay, in the last month. In the last 6 months, so 1, 2, 3, 4 for supraarachnoid hemorrhage, so 4 patients, 4 or 5 in the audience. So this is not, and I want to make very clear on this is not 700 LPs that we have to be doing to rule out this condition. We have to do it, and I am totally in favor of doing the LP, and my colleague will be discussing about promoting to the CTA. So anyway, this patient raised signs, low probability or high pretest probability that he may have a subarachnoid hemorrhage. Who will LP this guy? Or proceed to rule out subarachnoid hemorrhage? So 1, 2, very few people. Hopefully that will change. So the standard of care, based on the American Heart Association and the College of Emergency Physicians, essentially have a level B of evidence on doing an LP if you have a negative CT. Okay, so there is a lot of tendency nowadays to do a CT, a CTA in patients like this, and is this the right approach? Is that correct? The people, and what are we getting by doing a CTA? My simple answer to that is no. Okay, and this is kind of like pretty much at the end of it is no. You just don't do a CTA in somebody that comes with a simple headache. So this is another things that I just want to spend a few moments in here because this is important. Okay, so out of that number of small headaches that we have, so it has a bell curve distribution. So in one extreme, this is people that have neurological deficit. We're not talking about that group in here. We're talking about the people that have atraumatic, asymptomatic, normal neurological exam headache. The center of the bell-shaped curve show the people that actually present with a traditional type of subarachnoid hemorrhage presentation. And that's sort of like our group, our patient fall into that category. And Okay, so this group we have to rule out subarachnoid hemorrhage. And then there's this group that this is where we miss the problem. We have the problem. Okay, this is a group that that we miss and we don't pay attention, or it's confusing in this. So there have been several new Canadian rules, and people to help you out have come up with some research in trying to help out to stratify this patient into higher risk probability versus lower risk probability. So this is an important curve, and I think that people should kind of remember that. The majority of the people that have neurological symptoms is half of the patients that have subarachnoid hemorrhage. If we have 10 a year in a 50,000 visit ER, 5 of those will be with neurological deficit. They are no-brainer. They go to the CT scan, CTA, neurosurgery, and then we have to deal with 5 patients in there. So here it is, the lumbar puncture. People that are against, or I wouldn't say against, but that on favor of a CT angiogram, it's like, well, you're going to get an LP, it's a big needle going into your back. It's painful, it takes time, sometimes we don't get the proper result. And then, but we have this test, a CT angiogram, very easy to do. You can do it after the CT, painless, great. So which one do you want? So most people actually will choose the CTA. Nobody wants a needle in their back. That's the bottom line, Is that the correct thing to do? Again, I say no. So this paper is the one that has been kind of plowing through this, and it's an okay paper. I wouldn't say that it's something great, and it was published in Annal of Emergency Medicine. Can CT angiogram of the brain replace LP in evaluation of acute onset of headache after a negative CT? So it was a mathematical model. Okay, this is, I may have a coffee when I finish in here, or I may not. Okay, so 2 equivalent studies. The equivalent study essentially is like if you get a Bentley from here to Abu Dhabi, or you get a Toyota to here from Abu Dhabi, are they equal? One is more comfortable, but they both will get you there. So And then in order to do an equivalent study, it's like 3,000 patients that you need. So they could not do that because of time consuming. So they did a mathematical equation with a pretest probability of 15% starting the study. So at the end, they have this conclusion that I'm not too happy with. The first one is a CTA protocol can exclude subarachnoid hemorrhage with a greater than 99 post-test probability. Well, it doesn't. It doesn't. It just excludes aneurysm. Okay? So this is misleading. So when you're sitting down with the patient to discuss about the LP or CT angiogram, again, it's the informed consent of this patient. The LP should put you at pretest risk of missing an aneurysm of subarachnoid hemorrhage. And it's like, well, it's partially true. You miss that a 1% aneurysm, but you don't know, it could be a bleeding one that causes subarachnoid hemorrhage, or could be an incidental aneurysm. So why do we get into this sort of like debate or this mess, I guess? Surprisingly enough, if everything goes well, when you guys do the CT and the CT is negative, and you proceed to the NLP, and it's not traumatic, everything went well, so you have a sensitivity of 100% and a negative predictive value of 100%. So it's perfect. So patients do not have bleed, do not have subarachnoid hemorrhage. But surprisingly enough, if you review all the papers of the literature, some papers, this one is the 27% came from Jeffrey Perry, so one of the guys in Canada that actually I think that is the pioneer in really looking at subarachnoid hemorrhage in the emergency department. So extensive data, and 27% of the doctors, ER doctors who consider that somebody has a subarachnoid hemorrhage and they go ahead and do a CT, only 27% do an LP. And some other books quote 50%. So that's why the CTA kind of like came into the play. It's like, okay, so fine, we do a CT. CT is negative. Now we do the CTA perfusion, So if I find that the CT is negative, and then I do a CTA, and I don't see an aneurysm, so, I can tell you that you don't have an aneurysm, essentially. You don't have a bleed, and then you don't have an aneurysm. And so I'm done. And I kind of like agree to a certain extent with that. It's true. You don't have a bleed seen on a plain CT. Now, it all depends on the time when you do the CT, of course. And you don't have an aneurysm. So what you can tell this patient, well, if this aneurysm is not bleeding, or even if that is a cause of bleed, the likelihood of you dying from this is very low. Because it could be that bleed, if you don't see it, it's related to a perimesencephalic bleed or a non-life-threatening bleed. So problems with the CTA. So it's an anatomical, okay? It doesn't detect bleed. It detects aneurysms, okay? So the CTA protocol mislabeled a number of people. So we, if we are, let's assume that we're 100 in here, 2 of us will have an aneurysm, an asymptomatic aneurysm. Nothing to do, it's not causing anything, and even if you have a headache, you may have a asymptomatic aneurysm that is not the cause of the headache. And depending on the literature, it could be 2 to 7%. There was a big 8,000 study that they did in Japan, Germany, South Korea, and then they got the incidence of around 5.2%. And then by doing this, you essentially now are making somebody who is truly not a patient into a track of being a patient that need to have further investigation. And in i.e., they need to have an angiogram, and that carries risk. That's significant. And 2, it's like, well, depending on the center that you have, if you have a very aggressive neurosurgeon, they can have interventions for a potential asymptomatic or incidental aneurysm. And this is sort of like the key point on this. So what's the take-home message is not routinely. do not do a CTA. There is no evidence, nothing support this to be doing this, okay? And if you're doing it, you're diagnosing an aneurysm. Okay? Now, there are, even with the latest CT modalities and the 164 slices and the three-dimensional, you still do not detect bleeding in this. It's time for the shared decision making. Okay? So this is a time when you talk to the patient and then relay the right information. If I do a CTA, I can find an aneurysm, but that doesn't tell me whether that is bleeding or is not bleeding or will bleed. And the only, on favor of my colleague, these are the 4 occasions that I may consider as an alternative to do a CT angiogram. With the understanding that at the end of that, again, I will tell the patient, yeah, the CTA was negative, you do or you do not have an aneurysm. And that is the end of my talk. I hope that.
So the next speaker who will say for the yes is Dr. Latha Ganti.
Okay, so CTA for headache. Let's talk about a case. 54-year-old man, he comes in for sudden onset headache. It occurred at work. He describes it as severe, maximal at onset. And when you ask him, is this the worst headache of your life? He goes, well, I guess. It's the only headache I've ever had. So in his opinion, yes. And his past medical history is significant for hypertension and 1 pack per day smoking. His neuroexam is non-focal, and actually his headache gets better with morphine. So you could look at that and you could say, you know, he's probably a benign headache. So you could send him home, right? Well, this is what I get from the resident, and the neuroexam, at least in my department, is always non-focal. And so I kind of go back in there and I talk to the patient, and I find out that, yeah, it started at work, and actually he moves furniture for a living, and this started first thing in the morning, and he's here after his workday has finished, so it's been approximately 8 hours. He says it's severe and maximal at onset. And then he also mentions he's got this family history of Ehlers-Danlos syndrome, because like my residents hardly ever ask for family history, right? And actually neither do I before this talk probably, so in fairness. And then the neuroexam to me was reported as being non-focal, but actually when I did a neuroexam, he had some diplopia and neck stiffness. So I never buy neuroexam non-focal. So in fairness, 98% of headaches are benign, right? So it's migraine, tension headache, cluster headache, and as you know, migraines can present with all sorts of focal neurologic deficits that then resolve. And so yes, headache with badness is a rare entity, but we're emergency physicians, right? So we are looking for that 2% of secondary headaches that are bad. We're looking for subarachnoid hemorrhage, intracranial hemorrhage, meningitis, acute angle closure, glaucoma, cerebral venous thrombosis, tumors, temporal arteritis, vasculitis, dissection. These are all things that we care about. And that's why I argue that you should strongly consider CTAs for headache. So we've got some guidelines out there, mostly useless. The ESEM guideline is almost 10 years old now, and actually some of my really dear colleagues have authored this, they're not here, but anyway. An ESEM guideline basically says if they have anything, like if they have anything neurologic finding, or if they're over the 58 years of age, if they have HIV, then you have to do some kind of neuroimaging. The bottom one there says that if they have a sudden onset severe headache and negative findings on CT and LP, then they don't need a CT angiography. Now mind you, this is 10 years ago. AHA is much more liberal, and basically what they say is, you know what, if you feel like you want to do a CT angio, then you go ahead. Okay, so would I do a CTA? Absolutely. Why is that? Because I'm worried this person has a subarachnoid hemorrhage. Okay, before we go to neuroimaging, what about clinical decision rules, right? Everybody loves clinical decision rules, particularly in Canada. And I, of course, work on the other side, right? Canada doesn't have a lobby of lawsuit lawyers, and we do. So, auto subarachnoid hemorrhage rule. Can I use this in my patient? Well, he's over 15 years of age, and he's alert and oriented. He's got a new non-traumatic headache, and it did become maximally intense within an hour, actually within minutes. So seems to apply to him so far. The next thing, it says do not use in patients with new neurologic deficit. His diplopia cuts him out right there. Just kind of going through the other components. He's over age 40, right? He's 54, so that is against it. He has neck pain. There was no witnessed LOC, so that's negative. The onset was maximal, and it did occur during exertion. He describes what's a thunderclap headache. And so he has several things in there that are positive. It's important to know with the Ottawa subarachnoid hemorrhage rule, it is 100% sensitive, but only 15% specific. So it is a rule that you can use to rule out subarachnoid hemorrhage if all of those things are negative. And it's okay for that. I mean, I propose CTA, so I'm not that fond of the rule. However, you cannot use the rule to rule in or diagnose subarachnoid hemorrhage. So despite the fact that he has 4 out of those 6 factors, doesn't necessarily mean he has a subarachnoid hemorrhage. So there's a couple of studies that have looked at all this. So Perry et al. Did a multi-center prospective study, many hundreds of patients. And why did I tell you that his headache started when he started his workday, and then he didn't come till the end of his workday, and it's been about 8 hours? Because the timing of the headache matters. So it's been 8 hours, right? The cutoff that we generally use for CTs is, did you get the CT less than 6 hours from onset or greater than 6 hours from onset? And why do we use the 6 hours? It's because of the xanthochromia thing, right? So when you do a CT less than 6 hours, and they had, I can't read it from here, but I think it was 953 patients who had a CT less than 6 hours, their sensitivity for the CT was 100%. Once you went beyond 6 hours, all the patients who had the CT after the 6-hour mark, that sensitivity drops. And I'm sorry, I can't read the percentage from here, but I think it says 85.7%. So it drops significantly after the time. So our patient comes in, he's 8 hours out, and so do you think I could just do a CT and send him home? Absolutely not. Another study, very similar, done in the Netherlands. This was a retrospective study, 250 patients, and they basically found the same thing. When they do the CT 6 hours or more after the onset of the headache, the sensitivity drops to an unacceptable level. In this study, the negative predictive value of a CT scan was basically 95%. So that means you have a 5% chance of missing a subarachnoid hemorrhage. So what's the bottom line here on CT, LP, CTA for subarachnoid hemorrhage? Patients with a negative CT scan within 6 hours, their chances of having an aneurysmal subarachnoid hemorrhage is less than 1%. Adding an LP might give you some additional information, but when we talk about LP versus CT, and my colleague outlined this beautifully already, so I work in a busy emergency department, and like we always say that, and then I come here and I realize you guys see like 10 times the number of patients we do, so I really can't say I work in such a busy emergency department, but we think we're super busy. And we see lots of patients. We have a lot of patients that come in. They really don't volunteer their history. We don't do a very good job of taking the history. We're in a rush. We have a lot of patients. We have a lot of metrics we have to follow. And they come in, and you do a CT, and maybe it's negative, and maybe it's beyond the 6-hour mark. And like my colleague was explaining, you say, would you like to have a needle in your back? What do you think they're going to say? No. We have additional issues where we work. We have a large population of obese patients, and the majority of the time, my standard LP needle is not long enough to be able to do the LP. So that's an additional issue that I have. In terms of disadvantages of the CTA, usually what people say is, oh, you're giving extra radiation, and then what about the contrast? What about AKI? What about AKI? I mean, I can hydrate you. I don't think one dose of contrast is going to be that detrimental. And you're getting radiated. You came to the emergency department because you thought your headache was horrible. So if you thought everything was benign, then maybe you should have stayed home. But once you're in my department, the ante is up, right? It's on me to make sure that you're not in that 2% of cases that are going to have a poor outcome. Where I work, we have additional considerations. We work in the most litigious state in the United States. I practice in Florida. And this slide says, you're going to have surgery. Let me check my computer and make sure that you've not been a routine litigant. And I'm telling you, we actually have patients like that. My computer doesn't tell me if they've been a routine litigant, but dealing with lawsuits is something that we deal with, unfortunately, on a routine basis. In my state, we have 10 times the national average of malpractice for emergency physicians. Another case, because it's not all about subarachnoid hemorrhages, 34-year-old male, he presents with a severe right-sided headache. He says, it's as if somebody put a knife through my head. And then he says, I hear this like pulse in his ear. What do you think? Especially after you work like 3 shifts in a row. You think, oh, he's crazy. And I always have to deal with the crazy people, right? That's what you think. He has history of tension headache, he has history of migraine headache. So he has 2 of the most common headache symptoms, which comprise 98% of headaches. So you're kind of thinking, this patient probably does not need any workup, right? And he's a personal trainer. He works at a large medical center gym. 2 days ago, he was feeling kind of stiff, but he works out and stuff, so okay. He doesn't smoke, he doesn't use any drugs. He drinks 6 cups of coffee, which I've had more than that today. He drinks alcohol socially, takes some protein supplement, no other medications. And his neuroexam, guess what, is of course non-focal, right? So I go back in there and I examine this guy. Story is just about accurate. Now he elaborates on the HPIs. Every time another person goes into the room and asks the question, they add to the story, right? So he says, oh, well, I was feeling stiff, so my chiropractor friend actually set my neck straight. He gave me a little manipulation. Okay. Doesn't smoke, doesn't do any drugs, okay. And his exam, remember, was supposed to be non-focal, right? So I do just a very quick exam, and what do I find? His tongue's deviating to the side. Now remember, if you're just talking to a patient and they're lying in a stretcher and you're talking to them central, you are going to miss a lot of things on your neuroexam. You're not going to see that their tongue's deviating. You're not going to see that their pupils don't work in both directions. You're not going to pick up a lot of things on the neuroexam. So would I do a CTA on this patient? Absolutely, right? Why? Because I'm worried about a dissection. There's 2 types of dissections, right? Internal carotid dissections and vertebral artery dissections. Internal carotids are 3.5 times more common than vertebral artery dissections, and they're also more common in men. But together, they account for 1/5 of ischemic strokes in patients less than the age of 40. So you think young people, less than 40, that's pretty young, right? And they come in and they can have these vertebral artery dissections. You're not going to see that on a non-contrast CT. History of trauma is elicited 40% of the time. And what are we talking about? When we talk about trauma, what kind of trauma do we mean? We mean things simple that you may not even consider to be traumatic, but it's traumatic to your vessels here, right here in the neck. That could be any kind of martial art. You're doing some yoga poses, you're dancing, maybe a little crazy, you're painting your ceiling for extended period of time, blow your nose vigorously, or you got a buddy who's a chiropractor and manipulated your neck a little bit. All of these can contribute to the dissection being set off. In terms of symptoms, a lot of times they'll have an incomplete, painful Horner's. Now, you're not going to know if the Horner's is painful if you didn't even notice the Horner's, right? So that's a huge point here. 46% will have an audible carotid bruit or pulsatile tinnitus. So when he said he felt like he heard his pulse in his ear, he's not just crazy. That's actually pulsatile tinnitus, and almost 50% of patients with a dissection will have that. The most common cranial nerve palsy is the 12th cranial nerve, and if you just look at patients centrally and don't ask them to stick their tongue out, you'll miss it. So this is internuclear ophthalmoplegia, and this is my favorite thing to ask my residents. I always say, so did they have internuclear ophthalmoplegia? And they just go, oh my God, she's gonna ask me about the neuroexam now, right? And you can just see it, like their heart sinking, right? So this is when you look at the patient head on in the stretcher, they're gonna look just fine. Maybe you're on one side of the stretcher, and maybe that's the good side, and you won't notice that there's any kind of deviation. If you walk to the other side of the bed, or you actually have them follow your finger, then you'll notice that there's impaired abduction to one side. Vertebral artery dissections. You could have ipsilateral symptoms, you could have contralateral symptoms. These all have to do with the posterior circulation. And this is Horner syndrome, ptosis, meiosis, anhidrosis. Again, if you don't look, you will not find it. So imaging for headache, there's a couple things that are really important. Before we talk about imaging for headache, right, we have to think about what is your pretest probability or your suspicion for badness in these patients. So you can have all these fancy tests. You can have thrombectomy, you can have CTAs, you can have, maybe tomorrow we're gonna have a portable MRI, right? But all the tests in the world do not substitute for a history and a physical examination. So both my colleague and I will agree that no matter which side of CTA yes, no you stand, it is the history and the physical examination that forms the crux of your diagnosis and your ability to prevent badness. So you absolutely have to listen to your patient and examine your patient. And I think as we become more technologically advanced, that is one art that we lose. So in listening to your patients, what are red flags for headache? How many times do you go in? And most of the time it goes like this. They have a headache, right? You pick up the headache chart, and you go, okay, they have a headache. You already know. You're going to give them Reglan, you give them Toradol, and you're going to get them out. We have metrics. So we have door to doctor, has to be seen within 10 minutes. We have to put an order in the computer for a medication or an intervention within 10 minutes. So it's 10 minutes and then 10 minutes. And then we have to get the patient out within 100 minutes. So your clock is ticking, right? For the resident, for the attending, everybody. And then we get a base rate, and then they hold the rest of the money if your metrics are not held. So we work in this very, we have other issues in our system, I guess. So red flags: new onset headache in a patient greater than 50 years old, a thunderclap headache, posterior headache with neck stiffness. You don't ask about neck stiffness, they're not going to tell you. Change in vision, change in consciousness. Maybe they had a syncopal event before. They didn't think to mention it because right now they're not worried about the syncope, they're worried about the headache. Any history of HIV, immunocompromise. My patients don't volunteer that they have HIV. I have to ask them, do you have any medical problems? No. Do you take any medications? Oh yeah, ritonavir, this. I'm like, oh, so you have HIV? And then, oh yeah, kinda, okay. History of malignancy. Have you ever had any kind of cancer? No, I'm free. I've been in remission for 5 years. Look, so you've had cancer before. Okay. Pregnancy or postpartum. If it's obvious and they're pregnant, that's one thing. But many people are pregnant and you don't know. And as I said, we have a pretty large obese population, so it's always sensitive. You can't ask somebody, are you pregnant? I remember when that happened to me and I flew off the handle, so I get that. Fever, weight loss. Maybe they're afebrile right now in your emergency department because actually we take the fever like this. We take a wand, and it's a forehead wand, and literally it's a flyby. And I have to say that maybe 0.5% of my entire emergency department patients have a fever. Why? Because of the way we take the measurement. And any kind of relevant family history. As ER docs, I think we think dude, I don't do family history, okay? I barely have time to ask you why you're here and then get all my metrics done. And it's true, I feel like we do a bad job with family history. So those are all red flags and can be summarized by SNOOPS. I kind of like the acronym because you really do have to be a detective. Oh, and I can't read that. Okay, so historical considerations. Basically, when you are examining a patient and doing physical exam, in the history aspect, you really have to focus on your PQRST, right? How did the pain start? What was the onset? What made it better? Like, for example, if they're laying down and the pain is worse, then you think, that sounds like it could be increased intracranial pressure, right? It should be better. So that's a clue there. If they have any kind of cranial nerve palsies, you think, okay, wow, could this be a dissection? Could this be a subarachnoid hemorrhage? Because, with migraine, you could have some of those, but they are usually transient. Concerning neurologic exam findings, again, any kind of cranial nerve palsies, when they tell you weird stuff like I can hear my pulse ringing in my ear. And then other clues. Hypertension, of course, is a risk factor for ICH and subarachnoid hemorrhage. If they have decreased visual acuity, and visual acuity is another one of those things. Like they come in and they might not tell you they have decreased visual acuity. Like I need glasses for reading and distance, and I have visual hallucinations all the time. So I think it's just because I'm in this stage where the near and the far and the intermediate vision, nothing is working for me. But they might not mention it, right? Because if they deal with it on a regular basis, maybe that's normal. If they have any kind of vertigo, then they may not mention that too, because actually when they're sitting there, maybe they have no vertigo. Maybe it is exacerbated by position. And then papilledema. If you don't do a fundoscopic examination, you're not going to find papilledema. So in our emergency department, we do actually have an ophthalmoscope, and we could do an exam. However, even if we went as far as doing the exam, which unfortunately oftentimes does not happen, half the time the light doesn't work. So the bulb is gone, and good luck trying to find another bulb. So you don't even have the tools half the time. And how are we doing for time? Are we almost? We're done with time, right? Okay. So we actually put in a couple of other cases because we weren't sure how long it was going to go for. But anything to do with cerebral venous thrombosis, vertebral artery dissections, all of these causes of headache warrant a CTA. And this is why I say that CTA is warranted in a select group of headache patients, but you're never going to identify that select group if you don't do a history and physical examination. Thank you.
Good morning. My name is Omar. I'm an emergency physician. First, I want to thank you both for your talks. My question is to Dr. Latha. What is the false negative and false positive for the small subarachnoids on CTA? And my next question is, what is your approach for a patient who presents the second time to the emergency department with an incidental diagnosis of a small aneurysm?
Okay, so the first question was sensitivity of the study. So if you do a CT and a CTA, the negative predictive value of that combination is 99.4%. So I'm pretty good with that. 0.5 or 0.6% of patients might still have a bleed, and at that point we employ shared decision making and say, look, no test is foolproof, and this is what the risk is. So of course, if you have symptoms, you need to come back and do a good job documenting that. The second question was, what is our approach? So if a patient comes in, they have a headache, and maybe they had, I don't know, plain CT the first time, and then they come back a second time, or maybe they had no imaging. The second time, our threshold is very, very low for doing imaging or admission, whatever it is. So definitely, if you didn't image them the first time, I would definitely image them the second time. In terms of our approach, like I said, we are really moving away from CT LP and moving towards CT CTA.
Please.
I'm Chaudhary, emergency physician. My question is for both speakers. If patient present late, for example, present after 10, 12 hours, and history is very suspicious of subarachnoid, and you decide to go ahead with CTA because CT sensitivity drops after 6 hours, as you mentioned, what's the probability that this CTA will miss a small, say, warning bleed? And whether in this situation, MRA will be better option or just go for LP, old-fashioned LP?
I'll let you answer that.
So the first question about the sensitivity, you are correct, the sensitivity of the CT, plain CT, it does drop. So in order to answer that, you have to find out what do you have in your center. It is different animals now talking about a third generation CT versus a fifth generation, and now they are into the sixth, seventh generation with three-dimensional, either 64, 124, 128, 360. So that's the first thing. The latest study from third generation from Perry, 100% less than 6 hours, 97% around 12 hours, okay? And then it drops to 80s, something in the 48 hours or something like that. So that's issue number one. The likelihood of a CTA to diagnose bleed is none. Okay? Bleed. To diagnose an aneurysm, if the aneurysm is more than 4 millimeters, it's pretty good. If the aneurysm is below 3 millimeters, then they have a lot of miss in that range, so it's not that great. Now, taking into account that the aneurysms that are concerning, okay, if you read all the neurosurgery literature, once they get bigger than 7 millimeter, okay, then you start kind of like getting concerned about those ones. It's not to say that a small aneurysm cannot, it's not capable to bleed and kill a patient. Yes, and that's the biggest question about having CTAs in this patient. And the other thing is, like, once you get a patient that you tell them you have a small aneurysm, or come back if you have any symptoms, I guarantee you, if you look any cardiac literature or any other literature, like we always say, come back if you have a chest pain. That chest pain patient that you have seen for rule out acute coronary syndrome or atypical chest pain will be visited the emergency 3 or 4 times after you label them with a potentially incidental aneurysm.
Dr. Wazan.
Thank you for the lectures. Question for both speakers now. The awareness of subarachnoid is increasing, and we're having people getting coiled and have intervention. Now, how both of you would approach patient who had a coil already for an aneurysm, and he comes in with a bleed? Now, keeping in mind that these patients might get scanned, a couple of times, especially, young ladies or people who are, radiation is bad for everyone. So how would you approach a patient who has a coil already in place or an intervention that has done? Would you consider him, what's the threshold, and how would you deal with him radiologically or LP-wise?
So, I mean, the better test to do would be an MRI in that case, MRA. In
Not
my
at 3
center.
a.m., right?
What's that?
Not at 3 a.m. Not at 3 a.m. in my hospital, at least.
So never in my hospital.
Yeah.
It takes forever. People are admitted to get MRIs, so we cannot get an MRI from the emergency department. And so it would be a 48-hour thing. So if I'm the ER doc and I'm seeing this patient, I would definitely do at least a non-contrast CT. I do understand that it's another CT scan, but I'm so sorry. I mean, like, you're coming to the emergency department, you have a aneurysm in place that has been coiled or clipped or whatever, and you have a bleed. What am I going to do? So I would definitely image them. I'm not going to be the last person on that chart who touched that chart and didn't image the patient.
So you would involve his primary physician as well, right?
I would what?
You would involve his primary physician, I mean, the neurologist or
If
the
they have a
neurosurgeon?
primary physician, yes, and our neurologists are on call.
Yeah.
I comment on that. The case that you have is a very subgroup of patients, okay? And a very important subgroup of patients. Coiling versus clipping, you know, the trend now is coiling. Coiling tend to bleed, rebleed more frequently than clipping. So you have to take that into account. So they need imaging, you know, i.e. started with a plain CT, move up into CTA, or if you have a capability of MRI, but you need to involve the neurosurgeon involved. You know. And these are patients, you know, I feel your pain. These are patients that if they have a minor headache, they will be in the emergency because they have an aneurysm, they have a, you know, and then the first question that they ask you is, I'm concerned that I'm bleeding. That's number one question.
Absolutely.
And then, unfortunately, our job is just to prove otherwise.
Thank you.
Thank you, guys.